Today we are going to discuss intraoperative ventilative strategy, lung recruitment and perioperative lung protective ventilations. So I am going to demonstrate ventilative strategy, perioperative ventilative strategy and lung recruitment by using different models of Draeger anesthesia workstation, and I am going to demonstrate different methods of recruitment, lung protective ventilation on using lung and trachea cadaveric model of goat. Why we need to discuss this thing? Because all the patient under general anesthesia develop atelectasis, which ranges from 4 to 21% of the total lung volume and which contributes to post-operative pulmonary complications, and with the traditional way of ventilating in a perioperative period may also cause post-operative pulmonary complication as well as ventilator-induced lung injury, VILI. So I am going to demonstrate different ventilatory strategy, lung protective ventilation and lung recruitment one by one. So as we discuss, all the patient develop atelectasis. How it looks in vitro? So we are having goat lung cadaver, and I am going to set the ventilator as per traditional setting, keeping the volume control ventilation, keeping the tidal volume 300, presuming goat weight of 30 kg, 10 ml per kg I am keeping the tidal, keeping the respiratory rate 12 and PEEP 0 and keeping the FiO2 at 50. Look at the lung. See, this dark brown area are representing atelectatic area. This bright white structure are fully open alveoli, and this dark red color areas are atelectatic area. So as discussed, all the patient under general anesthesia develop atelectasis, and as we discussed, that ranges from the atelectatic area ranges from 4 to 21% of the total lung volume. So during intraoperative period, we need to take measure to prevent atelectasis formation. So how to do that? So there are different ways we can do it. So if we apply continuous positive airway pressure during pre-oxygenation only, which prevents atelectasis formation after induction. So low pressure is required to prevent atelectasis formations. So how to apply continuous positive airway pressure during pre-oxygenations? You can do it manually or through the ventilator setting. So if your anesthesia workstation is having CPAP mode, keep the CPAP mode on, keep the CPAP value between 5 to 10, increase the flow, and optimal mass fitting will deliver CPAP. And how much CPAP is delivering, for that you need to look at the pressure versus time graph. So another way of manually delivering CPAP is what you need to do: keep the APL valve closed at 10, shift the mode on manual spontaneous one, increase the flow, keep FiO2 100% and look at the pressure graph. With optimal mass fitting, this setting will deliver 8 to 10 CPAP, and which prevents atelectasis formation. So if you are not taking measure to prevent atelectasis during pre-oxygenation, if you are not delivering CPAP during pre-oxygenation, then most of all the patient under general anesthesia after induction going to develop atelectasis, as we have demonstrated how atelectasis looks in the goat cadaver. So what are the ways to open atelectasis once atelectasis are there. The measure, the method, the procedure, the technique to open atelectasis is called lung recruitment. So, recruitment is a process, is a measure, is a method, is a technique to open atelectatic alveoli. Literature describes various methods of lung recruitment. One is vital capacity maneuver, second vital capacity maneuver followed by PEEP, third only PEEP, fourth step by increase in inspirative pressure and PEEP, and fifth one is BiPAP and APRV. So, we are going to demonstrate each method in detail over the lung goat cadaver. To open atelectatic area, it requires higher pressure to be generated. So, first method is vital capacity maneuver. Now, what is vital capacity maneuver? To maintain sustained pressure of 40 centimeter of H2O for 8 to 15 seconds, and this measure will open almost all atelectatic alveoli, and that I am going to demonstrate by using this anesthesia workstation and goat lung cadaver. So, this is ventilatory setting is 40% FiO2, 300 tidal volume, 12 respiratory rate and I ratio 1:2, and look at lung how it's been ventilating. So, this again brown area representing atelectatic, we need to open it. As described in vital capacity maneuver, change the ventilatory setting is a manual method of delivering vital capacity maneuver. So, vital capacity maneuver, to deliver vital capacity maneuver, change ventilatory setting. This is the manual way of ventilating, delivering as vital capacity maneuver. Change ventilator setting, keep the ventilator on manual spontaneous, keep APL valve closed at 40 centimeter of H2O, increase the flow to 15 liter and look at the pressure and look at the lung. So, gradually 40 centimeter of H2O pressure is going to be built up into the lung, and once it reaches the 40 centimeter of H2O, keep it for 8 to 15 seconds. This will open all the atelectatic areas. So, this is called vital capacity maneuver. So, it should be given for 8 to 15 seconds and then start with the conventional ventilating strategies. Now, look at the lung surface compared to the previous one. So, there are more bright structure compared to the previous one. Another way of delivering vital capacity maneuver is with the pressure control ventilations. Change the setting, keep the FiO2 40%, change the respiratory rate to 4, keep the inspiratory time 7.5 seconds and increase the pressure to 40. So, this setting will deliver 40 centimeter of sustained pressure for 7.5 second of inspiratory time. When we keep the rate 4 and I ratio 1:1, it will deliver 40 centimeter of sustained pressure for 7.5 seconds. So, within this time, this will open all the atelectatic area of lung, and then once you recruit the lung, start with the conventional setting of pressure control ventilation. Showing vital capacity maneuver followed by PEEP. Change the ventilator setting to manual spontaneous, keep the FiO2 40, increase the flow to 15 and keep the APL valve closed at 40. Look at the lung is gradually expanding and maintain sustained pressure for 8 to 15 seconds, and this pressure valve is reaching the 40 centimeter of H2O, and keep it there for 8 to 15 seconds. once you recruit the lung, it should be followed by 8 to 10 centimeter of H2O PEEP, either with pressure control ventilation or volume control ventilation. So, traditional way of ventilating a patient in intraoperative period, either volume control ventilation or pressure control ventilation with 8 to 10 ml per kg tidal volume, many times leads to ventilator induced lung injury by causing volume trauma. So, in perioperative is a normal lung, and there are higher chances of developing ventilator induced lung injury in normal lung compared to diseased lung which we are ventilating in a ICU. So, we need to take measure to prevent ventilator induced lung injury intraoperatively, and that can be done by lung protective ventilation. Now, what is lung protective ventilation? It is comprised of low tidal volume 6 ml per kg body weight, 6 ml per kg predicted body weight, high PEEP, keep the expiratory ratio 1:2, but in case if airway pressure is increasing, then change the inspiratory expiratory ratio 1:1. You can use volume control ventilation or pressure control ventilations. If you are having volume control ventilation or pressure control ventilation with volume guarantee, that is a better mode. Keep the FiO2 as low as possible, up to 30 to 40%, and keep the plate pressure less than 30. That is complete lung protective ventilation in intraoperative period. So, there are different theories, different concepts of protecting lung intraoperatively. One is open lung concept, means start with the CPAP in a pre-oxygenation, continue with the CPAP intraoperatively and extubate the patient over the CPAP, means apply CPAP throughout the perioperative period, which keep the lung, keep the alveoli open throughout the perioperative ventilation and perioperative period. That is called open lung strategy. The second strategy is driving pressure concept. What is driving pressure? It's a pressure difference to accommodate optimal tidal volume for optimal gas exchange. So, normal driving pressure is 13 centimeter of H2O. Driving pressure means plateau pressure minus PEEP. So, when you are ventilating a patient, keep the plateau pressure minus PEEP less than 30. If your requirement of plateau pressure is going high, or if your requirement of driving pressure is going high, if your patient driving pressure increasing beyond 30, that's the indication of lung recruitment. So, with Atlan, so once you set PEEP and once you set inspiratory pressure 13, so this inspiratory pressure 13 will be delivered above the level of PEEP, and once you change PEEP from 5 to 10, automatically inspiratory pressure increase and keeping the driving pressure same. And we will demonstrate the different driving pressure, how it looks on the pressure versus time graph in a different anesthesia workstation, showing the driving pressure concept with the volume control ventilation. Look at this, peak airway pressure is 22, plateau pressure is 18 and PEEP is 7. So, driving pressure is plateau minus PEEP, that is 11 in this case. So, ideally it should be less than 13, that is normal. So, this is with the volume control ventilation. Here we are keeping the driving pressure at 13. So, setting our inspiratory pressure in pressure control ventilation is 13, PEEP 0. So, look at this, here plateau minus PEEP is less than 13. So, the advantage of using this machine, once you increase the PEEP, it keeps the driving pressure same. If you are withdrawing the PEEP, circulation